Thank you so much. It's amazing when you hear somebody say she's been working at the Cross for 20 years and you think, how can that be? I swear I'm only 28. But anyway, somehow the maths is in there. Tēnā koutou, tēnā koutou, tēnā koutou katoa. It has to be said that there's been various mentions of singing, both Johan talking about how he wasn't going to sing Madonna and then some beautiful haunting singing from up here and at the back. You all need to rest assured there will be no singing from me, and trust me, that's a really good thing. So my name is Marianne, and I come from the unstable Pacific nation to the west of you, where we seem to change prime ministers the way most people, I don't know, change their socks. So it's lovely to come and be at the conference here. And I guess the question that was asked of me is, does New Zealand need/want a supervised injecting facility? So we'll kind of meander through some various ideas about that, and you can tell me whether or not we've answered that at the end. But obviously the first thing, anything where we're in public health, whatever, the first question is always define the problem or put some definitions in. So an MSIC, or a medically supervised injecting centre, is a, firstly, legally sanctioned facility. So it generally has a piece of legislation, and we have a piece of legislation which allows us to operate, that enables the personal consumption. So the legislation that allows us to operate only allows the possession of small quantities for personal use and the self-administration of previously obtained drugs. So we're not a heroin prescription program or a hydromorphone program. People are coming with pre-obtained, pre-purchased substances, and they're using those under the supervision of qualified personnel in a non-judgmental environment. So that both tells us what we are as well as what we aren't. And the reason I think that definition is important is because it leads me to think, what was the big leap here? People go, oh my goodness, you work at a supervised injecting facility, as though there's something kind of quite extraordinary about that. But New Zealand, you guys put in place the first national funded needle syringe program, as far as I'm aware, in the entire world, if that's right. You should be extremely proud of that, and your rates of HIV are far better than ours. We're pretty proud of ours. It's about 1%, and yours are less than that. So needle syringe programs are also legally sanctioned services where they supply clean injecting equipment, as we do at supervised injecting facilities, for people who inject drugs that are, with pre-purchased, pre-obtained drugs for their personal consumption. And it's done to prevent the spread of bloodborne viruses. And again, you lead the world. New Zealand leads the world through their needle syringe programs in terms of rates of bloodborne virus transmission amongst people who inject drugs. But 20 years ago, when I started working in the Cross at a service that provided clean needles, and all over this country, 4 million syringes are provided every year, think about what actually happens, because you're acknowledging that somebody's injecting drugs, you're probably talking to them, connecting with them, trying to link them in with other services and being a good NSP worker. But at the very core, you're acknowledging that people are injecting drugs and you are providing them with the equipment to do that. Surely that was the leap as a society, the provision of clean injecting equipment. The only difference is, when I started work in King's Cross and I would provide that clean injecting equipment with a smile, with a please come back, with a is there anything else I can do, with a what else can I help you with, I then said, you must now go away. And so if you look at the top photo, I was saying to people, go back to wherever it is that you inject drugs, because I care about you enough to prevent you getting or spreading HIV, but apparently I don't actually care quite enough to be concerned enough for your welfare. And you know why that is? Because the justification for needle syringe programs is because they protect us. because we see them, the people in our community who use drugs, as vectors of disease. And so if we can keep them disease-free, then needle syringe programs protect us. Deep down, that is the basis for why we got that incredible government support, because it was the threat of HIV and a sense of we have to do this because of the threat of an epidemic. And we've been incredibly successful and everybody's very proud of it. But we are saying turn away, go away. That is not the practice of good medicine. So all we say at our centre is, yes, here's the clean injecting equipment, all of that engagement that good NSP workers do, and then we stop saying, go away. We say, you are welcome, choose a booth, I will bear witness to what it is I know you're doing, but I had to pretend in any other circumstance that I didn't. I will sit beside you, metaphorically as well as practically, and I will bear witness to the everyday reality of your life, which is injecting drug use, without stigma, without shame, without judgment. And if there's an immediate adverse outcome, I can do something and the staff can do something. But then it also allows a place and a space for connection. I would argue that no matter how amazing needle syringe services are, at some level they fail in their duty of care, because we acknowledge what is happening and we send people away to an inherently more unsafe environment when we know exactly what needs to be done to stop them dying of overdose. When somebody has too much opiate of any kind, whether that's morphine, oxycodone, heroin, fentanyl, you name it, they have a respiratory arrest, a little bit of their brain is switched off and they forget to breathe, and that's why they die. So how many overdose deaths have occurred in our centre or around the world? None, because you just have to be there. So if you look at the photo on the left versus the photo on the right, it kind of, to me, is pretty obvious which is the preferred scenario. When I first started working in King's Cross and at a service where obviously we gave out clean injecting equipment, we saw street kids, people who injected drugs and people who worked in the sex industry. And I put a lot of people on drug treatment, did a lot of primary health care. And I remember one day being really shocked because somebody used in the toilet. And, I sort of got a bit hoity-toity, and who did they think they were? And it was quite stressful because we had to try and open up the lock because he'd dropped, and faffing around trying to get the Narcan out. And so, my excuse to myself is I was a bit stressed. That's why I was... What did I think he was going to do? I just provided him injecting equipment. Where did I think he was going to go? Where did I get off getting, offended because he was using the toilet? Shouldn't I have been glad that he used in a toilet so we were there when he overdosed because he lived? So of course we all know this, but the context around drugs and the people who use them mean that we can't really make our decisions very well or very clearly. We get a bit confused about what the problem is, which means it's not surprising that we're not quite sure what the solution is. And it's because of all of the feelings and the emotion, both that we see from our peers, from our media, from our colleagues, from our co-workers, from our family, from our politicians, from people with lived experience themselves, who often have far more internalised shame and stigma than even sometimes we heap upon them. And obviously that gets in the way of good policy. One of the things that I've learnt, though, at the supervised injecting facility, for better or worse, is that the media doesn't always have to be your enemy. So this was the front page of our local newspaper back in 1999. And I can remember it as if it was yesterday, we give our kids heroin injecting kits instead of help. Now the health minister admits it's wrong. Now that was obviously an enormous thing for those of us working in the industry at the time. And, if you could read the caption, it purports to be a 12-year-old boy. He was not 12, he was 15. He was paid for the photograph. And as a result of that, where I used to go on outreach and provide primary health care in an area called Redfern, which was sort of the closest you'd get to a ghetto in and around Sydney, they suspended the legal distribution of needles for a period of time, as if somehow that was going to make the problem better. Funnily enough, though, as a result of this front page headline, the Premier at the time said, if elected, a couple of months after this, if I'm re-elected, I will hold a drug summit. The drug summit did occur. There was 172 resolutions, one of which was not to veto a community proposal for a supervised injecting facility. Another 2 years later, we finally opened. We are funded by the confiscated proceeds of crime. We had a specific piece of legislation. We were trial for 10 years. You know, a lot of stuff went on. But in a funny way, you can trace it back to this photo, which at the time we thought was the worst possible thing that could have happened, and yet good things came out of it. So I've just got 2 slides now, which are very, obvious and simple, which is about what are the aims of what we do. So supervised injecting facilities are about acknowledging the reality, reducing the death and the injury associated with drug use, and most specifically about drug overdose. Because we provide clean injecting equipment, we reduce the transmission of bloodborne viruses like Hep C, HIV. We reduce the amount of discarded injecting litter on the streets, and that's one of the reasons that local communities, not just in Sydney and in Melbourne, where we now have a supervised injecting facility as of the 30th of June this year. Woo! But that's one of the reasons why local communities all around the world are very supportive of injecting facilities, because they've been the ones that have been forced to deal with the reality of needles in and around their streets and their backyards. And then obviously the last one is about increasing contact and connection with people who may not be accessing other services, because they're not coming to us as a health service having made some leap about there's something wrong and I need some kind of help. So in the stages of change model, for anybody that's into health promotion, they can be in the pre-contemplation phase. They are just coming as a means of having a safe, non-judgmental space where they're not going to get jumped on and they can use drugs that they are intent on using. So in that sense, it's a net widening effect. We've now been open 17 and a half years. We've had more than, it's probably closer to 1.2 million injections on site, more than 8,000 overdoses where we've intervened. Probably a third of those has been where somebody has stopped breathing altogether, turned blue and been absolutely unable to be woken up. So the lowest form of sort of decreased levels of consciousness that you can have. No overdose deaths. 16,500 individuals have registered to use the service. In any typical month, we would see about 600 or 650, so it's a bit of a moving feast. People go in and out of jail, in and out of treatment, in and out of using. And more than 13,000 instances where we've been able to refer someone on to health and social services. About half of those for addiction treatment, but a whole bunch of other stuff in terms of teeth, primary health care, housing, legal assistance. So to me, that's kind of all you need to know to get the point, I guess, of supervised injecting facilities. I've got a short video because I was thinking it's getting to be the afternoon tea time. People need a little bit of something, especially those of you up the back. So I've just got a short, I think it's about 6 minutes, which the people in it are our staff, but it shows really clearly, in fact, how the service works. So if technology is on my side, and hopefully the sound is coming up, whoever's doing sound.
Sydney's first legal drug centre hasn't won over all its critics, but it still looks like it's here to stay.
Well, the truth is heroin use happens, and the challenge for society is how to help those addicted survive and eventually get clean.
It wasn't going to be a magic bullet, but it was going to be better than the alternative.
This is the story of Australia's first and only medically supervised injecting centre, the Sydney MSIC.
Alright, Sammy, you can go through. Thank you. Hi, Maria. How are you doing today?
I'm bad.
I lost a girlfriend in Melbourne who overdosed in this alley where everyone used to go.
What was your password?
That infuriated me. We're so lucky up here.
What are you having today?
We're having heroin today. I haven't had anything for 4 days.
My son and my only child, Daniel, died this time last year from an accidental heroin overdose. He died alone in my car. He was 28 years old.
We really need to remember that drug users are people that might be your son or your daughter. They might be your brother or your sister or your next door neighbour or your friend's child.
I'm afraid there's no vacancies at the moment. Can you take a seat?
How long is it going to be?
It shouldn't be too long.
Daniel was an intelligent young man. He hated what it did to him, but he was gripped with addiction.
Speak to people who smoked for a lot of years, and usually they've tried a number of times to come off. Doesn't matter what drug you're talking about, it's a chronic, relapsing condition.
We've had people say to us, well, just simply tell him to stop. If only it were that easy.
What's your password?
We don't have a password.
You've never been here before?
No.
Alright, you need to complete the registration form.
So a supervised injecting facility is a premise where people are allowed to come in and inject drugs. They have brought those drugs with them. We don't provide the drugs.
We provide a safe, clean place for them to inject. We provide them with the equipment. We also have professional staff on board.
Do you want to come through? Right there.
So when people walk into 66 Darlinghurst Road, there's a reception desk. If it's their first time, we get them to register with the service.
So registration takes about 5 to 10 minutes, is that okay?
Oh yeah?
We're just going to take some really basic information from you.
We take a brief history and then people provide us with a password for the database.
So all of this is confidential, is it?
This is confidential, yes. How long have you been injecting drugs for?
About 20 years.
About 20 years. What would your drug of choice be?
Heroin.
We do have exclusion criteria. Anyone that's under the age of 18, has not injected drugs before, is with a child or is pregnant, under our licence conditions is not able to come in and use the service.
Thank you. Maria, you can go through.
Also, importantly, we have an intoxication exclusion criteria. This is important in terms of the safety of the person themselves and also the staff.
Maria is coming through. She hasn't used in 4 days, and she's got some benzodiazepines on board. So just keep an eye on her. What I did with Maria was I rang through to let them know that she hadn't used in 4 days. She was in a great risk of overdose.
Hi Maria, you having heroin?
Yeah.
Okay, here's your bits and pieces. Now I know you haven't used for a wee while, so I'm going to give you a couple of fits, so maybe just have a taste first. So this is stage 2, and this is the only place in Australia where it's actually legal to inject drugs. And don't forget to wash your hands. So the main role of the staff in this stage is to supervise the clients while they're injecting and then to monitor them for any kind of signs of overdose. So we're always checking on people. We go over to them, we just give them a little tap on the shoulder and we ask them, are you okay? Most of the time they can respond to that, sometimes they can't, so that's when we step in.
What we know is that because we're able to intervene so early, we are able not only to save people's lives, but we can prevent some of the injuries, and they can be catastrophic injuries as a result of drug overdose.
You okay, Sammy? Yeah, what?
When somebody has a heroin overdose, they stop breathing. If you are waiting for an ambulance or waiting for even somebody to call an ambulance, people can suffer brain damage.
Hey Jack.
If the person's not breathing themselves, then what the staff do is bag the valve mask resuscitation.
Can somebody grab me the oxygen?
Until the person either comes around or
I'm going to grab some masks.
Great, come down to 59.
under our protocols, the nurses give 800 micrograms of intramuscular naloxone, or Narcan as it's called, and that will reverse an opiate overdose.
Okay, really ready with Narcan. Let's give it a 1740. Hey Jack.
The reality is there's about 90 of these facilities all around the world who have seen millions of supervised injecting events. There has never been a death from drug overdose in any of those injecting facilities reported anywhere in the world.
You dropped me.
The Injecting Centre has successfully managed just under 4,500 overdoses since we opened.
99%. Good work, folks.
So I think that's a really powerful statistic alone on the benefits of supervised injecting facilities.
That's pretty serious.
People then discard of the equipment and they move through to the stage 3.
This is Will in. Can I see him?
Yeah, sure.
It's an opportunity for them in a relatively relaxed setting to have contact with health professionals to learn more about treatment options.
Hey, well, can you have a chat with Maria? She's not looking too good.
Yep. There's counsellors and nurses in this section who can engage them in discussions around treatment to detoxes or pharmacotherapy or rehabs.
We provide information around methadone treatment, buprenorphine treatment, residential rehabilitation, the whole range of treatment services that are available.
Sounds like you're a bit fed up. You've reached your limit.
I have reached my limit. I've been doing this for way too long. I just had a shot just now. I've been holding off for a whole week at the shirt.
The reality is that most of the people we see have suffered quite devastating childhoods, often, where abuse and neglect is the norm.
People look at homeless people and people begging and whatever, and they think, look at this piece of shit, but they don't realise they're just ordinary people like them, but something in their life has crushed them.
The people we see here, they're already a stigmatised, discriminated group of people through their injecting drug use, and here they actually get treated like human beings.
Oh, hi Jane, it's Will from MC. I've got Maria with me. She's keen to start on a pharmacotherapy program. How soon can we get an appointment?
At the moment we see about 700 or 800 people every month. At the moment we average during the week about 220, 230 visits a day.
We've treated over 4,000 overdoses successfully. We've made more than 9,500 referrals. So yes, we're doing extraordinary work here.
The medically supervised injecting facility is totally funded from the confiscated proceeds of crime. It means that the money that funds our service is not directly competing with drug and alcohol treatment services.
Drug use should be above politics. It should be treated as a medical issue rather than a law and order one.
Police reporter Brendan Roberts travelled to Sydney's King's Cross, where locals say the rooms are making a big difference.
100 to 130 needles a day was our average day. Since the injecting centre, if we get a day where we would have 2 needles, we would think we were having a very bad day.
These days, addicts get their fix off the streets and behind frosted glass, and critically, they always walk out alive.
It's a good video. We've updated it. You can see the statistics in there are getting a bit old. So we've updated it, and I have still know Judy, who lost her son Daniel, and Daniel was one of the clients of our service, and they moved to the Blue Mountains, which is an area that obviously doesn't have a supervised injecting facility. And he was having a bad day, and he was found out the front of his dealer's house, slumped over the wheel of her car. And, you know, she says there was nothing that there was nothing I wouldn't have done for Daniel. And, you know, it's pretty hard to look a parent in the eye when you know that, you know, every overdose death is a preventable death. Very quickly, for those of you interested in evidence, I have the latest review of all available papers about what the medical evidence says about supervised injecting facilities. They do work, they do stop people dying, they do reduce ambulance call-outs. Importantly, they don't just have effects about the pure and simple immediate after effects of overdose. It's also about making connections with people. And the work that's been done in Vancouver, where they had a cohort that existed before the opening of their service, and they were able to follow up the groups of people that used the service and the groups that didn't. And they showed that the people that were accessing the service were actually far more likely to go into detox and therefore rehab and drug treatment services than those that weren't accessing the supervised injecting facility. They also don't have the negative effects that people were sort of screaming out for. This is going to be a honeypot. This is going to, you know, make the place, you know, worse than it was. Nobody's going to want to get off drugs because it'll be so easy to keep taking them. Very clearly, they don't do that. They've also got other benefits in that we actually get much more of an insight into what's going on. So at the moment, obviously, with the threat of high-potency opiates like fentanyl and fentanyl analogues, wreaking devastation across North America, we can run a sentinel surveillance site where we're actually testing people's urine for fentanyl. So far, there's not evidence of fentanyl contamination in the heroin in Australia as yet. I hope that remains the case. And also we can start having conversations about the broader debate because, of course, as I said, the big shift was made when we started providing the clean injecting equipment. This shouldn't be a big shift, and yet it is. Why is that? Because the law is an ass, that's why. Because we still have a system where if somebody is in possession of a small quantity or self-administers, they can be charged with a criminal offence. That's not right. And so it allows services and organisations that run such services to start to have a platform for advocacy. And I have to say it's extraordinary. I don't go to church. I work for an organisation that is the services and advocacy arm of the Uniting Church, but I've never been, wasn't on my job description whether or not I had to believe in God, which is just as well. But the Uniting Church has actually now funded a campaign which is about to launch. So on the 12th of October next month, we have Richard Branson coming out with another member of the Global Commission on Drugs at the Town Hall with some photography from Nigel Brunston, who's a harm reduction photographer in the UK, to talk about the fact that we need to do things differently and we need to do a bit of a rethink. And then a week later, on October the 19th, we start a long walk to treatment to highlight the reality that in Australia, in regional and rural areas, people don't have access to treatment because it's too far away. So we're going to start a long, lonely walk where one person is going to be delivering a petition and handing the baton on to someone else and someone else and someone else, from Dubbo to Sydney, which is going to take 14 days to walk, because that's how far it is for that person to get to appropriate drug treatment in Sydney. So that's exciting. That said, my original question, does New Zealand need or want a supervised injecting facility? The reality is I don't think you need or want the service that I have, because I don't think you have King's Cross. My understanding of your data is that you don't have highly concentrated areas of large numbers of people overdosing, significant numbers of overdose, and concentrated public amenity issues and discarded needles. There are obviously increasing places and services around the world that are taking up supervised injecting facilities as an option. And so when we opened, there was, I think, 40 or 42 such services. You heard me say in the film that there's now about 90. In fact, now there's probably more than 120, largely through Canada, where Canada went from having 1 to 28 in the space of 12 months. Norway, Luxembourg have opened, Denmark's opened, France opened 2 just a couple of years ago, Belgium has opened 1 this year, Ireland is on the cusp of opening 1, Scotland wants to open 1, Portugal is in discussion about opening 1, the USA has an undercover 1 operating, and a number of states that want to open 1. And they are a local solution to a local problem. So they can be purpose-built, like us, or you can set one up within an existing service, which I've seen a number of that operate, for example, in Spain. They can be a standalone service like us, or integrated within another community health or drug and alcohol or primary healthcare service. Ideally, they're legal. Sometimes they're not quite. Sometimes they're actively illegal. But you do have to have the support of the local police in order for them to work, because otherwise the police are just going to keep nabbing everybody on your front door. They can be a building. They can also be mobile. In Barcelona, they have a bus that goes out, and a couple of other cities in Europe, they have buses that go out, as well as a couple in Vancouver. And they can be big services around or not. So I visited one that literally has a room within an existing HIV service called the Dr. Peter Centre in Vancouver. And it's within a service that provides all sorts of other stuff, and people can go there, and at a maximum you can have, say, 2 people. So they're very much a local solution to a local problem. But the problem, of course, is the law. That's the conversation we should be having, because what stops you opening up any injecting centre, what stops me as a doctor, not just in New Zealand, but anywhere else in my state, when all day, every day, I see people and I respond and I intervene and I make sure that they have enough oxygen so that their brain doesn't suffer, if I walk outside of my front door and that same scene I am faced with, the law impacts on what I can and can't do. That's crazy. That's just crazy. Because, as I said before, good needle syringe services, as good as they can be, give you syringes to go out to that, when the alternative is so obvious. So, Hopefully, you now know both what a supervised injecting facility or a medically supervised injecting centre is, as well as what it's not. And the biggest myth is that we're a heroin prescription program. No. People bring their own drugs, they're pre-obtained, pre-purchased, with all of the lack of quality control and all of the potential contamination that goes with that. But it's not a big leap, because all we're doing is not turning them away. There's very good evidence behind the benefits, and there's different ways you can implement them, and different models are possible. But we desperately need to change the laws, and alongside of that, we desperately need to change the dominant narrative, and that is where people in this room have the capacity to make a difference. Yes, it is all about connection, and it's up to us to have those conversations. And this is an obvious list, but we know, yes, we have to have a connection with our clients and we have to give them their voice. We have to not forget that they have families and communities, and we have to be part of that and work with that as well. We have to work with each other. I don't know what New Zealand's like, but in Australia, there is still some that say abstinence and harm reduction are at war with each other. Really? Abstinence is a very effective form of harm reduction. If you're not using, you're not going to suffer harms. And that doesn't work for everybody on every day. So there's other stuff we just have to do. We don't have to be at war with each other. We're on the same side. We have to connect with our local services and be client-focused and work out what's right for them. We have to speak to police. We have to speak to justice. We have to speak to media. We have to speak to other community leaders. Consider reaching out to the faith-based community. That would have been absolutely outside my frame of reference. And yet when I began at the supervised injecting facility, when stuff was in the media, I would call out the Reverend Harry Herbert, who was my boss, and say, Harry, put your collar on and come and stand beside me while we talk about the sanctity of human life. And I tell you what, it sounded an awful lot better coming from him than it did from me. So I thought I would finish by just mentioning some of the things, I guess, that I've learned in my journey, and by no means do I feel like I don't have a long way still to go. But we do need to work out what it is that we're trying to fix. We can get ourselves, our knickers in a twist about saying everything's broken and everything has to be changed. Yep, sure, but what is it that we're trying to fix? Are we trying to stop overdose deaths? Are we trying to stop stigma? Are we trying to increase access to treatment? Are we trying to get positive press? Are we trying to get more money? What's the money for? Actually be very clear in your mind what it is that you are actually trying to fix, and sometimes the solution becomes a bit more obvious. The next one is particularly important sometimes, I think, for people like me, both because, as you might tell, I could probably talk somebody to death under concrete, but also because we need to listen more to people with lived experience. I have to acknowledge that people in my profession have and continue to be sometimes inadvertently, as well as advertently, disrespectful about the fact that I know best because I'm a doctor. And I've learnt more from the clients that I've had the privilege to work alongside than I probably could ever have learnt from anyone in the medical profession. So we always have to think of and include people with lived experience. Our language is important, and it starts with us. I have to write a commentary on a paper for addiction about something, and I have to begin that with saying, this is a great paper, but when you're talking about abuse, that's not right. Do not use the word substance abuse, because when you hear the word abuse, what does that make you think of? What are we inherently saying about the members of our community? We, every one of us, should never use that word. We should never use that word, because this is everybody's business. The other thing is we should speak up. Some people don't like talking at conferences. Some people don't like talking in cafes or to taxi drivers or to friends over the dinner table or family members. Not only even when you don't feel like it, but especially when you don't feel like is exactly when we need to speak up. And we need to speak with people who think differently to us. It's very easy to surround yourselves by, like-minded kin. I'm guilty of that. I need to have the conversations with people that think what I do represents the devil. And I need to listen, and I need to engage if we're ever going to make a shift. And finally, we really need to embrace positive change, and any positive change, and celebrate those small wins, because this is a marathon, not a sprint. So finally, there was a couple of things I learnt just in the day that I've been here and been talking to people that are relevant, I think, for Australia versus New Zealand. You had the first national rollout of a funded needle syringe program. Brilliant. One-for-one exchange, are you kidding me? Can you get rid of that? That's crazy. The whole point is to flood the market with clean syringes so that every single time somebody uses, they do not reuse a syringe. You need to get clean syringes out there, and people should not pay for that. GPs can't prescribe methadone. Right, so we can prescribe fentanyl, we can prescribe OxyContin till the cows come home, we can prescribe the things that cause problems, but we can't prescribe the medicine. Take home naloxone. Naloxone is a simple drug that does nothing except save your life if you're dying of an overdose. We need to flood the market with that too. And doctors can prescribe it. Prescribe it to your patients who may be at risk of overdose. They may use it for somebody else, but if you prescribe it, you have justification for doing that, and you will save a life. And as somebody said to me, the first time you hear somebody come back to you and tell you the story of when they used it, you'll write another 10 scripts the following day and 20 the day after. And finally, know the problem. How many ambulances are going out to accidental opiate overdoses in your communities? I'm not sure you know. How many deaths are there? We need to have good surveillance systems in place to monitor the problem and monitor trends. Otherwise, how do we know what is the problem that we're trying to fix? So finally, this is a framed quote. I've got 3 of them, a couple from Eleanor Roosevelt and this one that says, "Until such time as decision makers hear the voices of the vulnerable, advocacy with all its inherent risks remains the responsibility of all," and then I need to cross out physicians and write people. To me, it is an absolute privilege to belong to a community of harm reduction heroes, for want of a better word, and people who genuinely care. I felt like I found my kin when I found this community of people who are really prepared to stand up, but that is what we need to do. We need to stand up, we need to change the narrative, we need to change the laws, and we need to do it so that we can celebrate and not be dead at the end of it. Kia ora, thank you.